Hello, my name is Madison Tuberville, and I'm doing my CSI QSIN feedback. For number 1, I tried a few different therapeutic techniques that enhanced communication with the patient. So my patient was explaining to me how she was admitted to the hospital for a drinking problem, and she was admitted by her husband, who also drinks. I asked her, "How do you feel about that?" which was encouraging expression, and then to her response I said, "I understand how that can make you upset," which acknowledges her feelings, but it doesn't make it about me, and it also doesn't have me taking any ownership over the problems. My communication could be improved by being more patient focused. So whenever I was going into the room with the manic patient, she was very preoccupied with her project, and she was also very focused on getting out of there, getting a phone. I was very focused on getting her meds. From her perspective, I was introducing an unrelated topic because she had voiced to me her concern: I need to use the phone, I need to cancel the tickets, and I moved on to the next thing without addressing her worry, and that led to her becoming frustrated and attempting to leave the room. When the patient began to cry and show behaviors of paranoia, it made me feel sad and a bit hopeless. So I was a shadow for that simulation, but it was just difficult because that hallucination is so real to her. I didn't know how I would reassure her in that moment. I know I can say you're safe, but to her that is so real. So it did make me feel a bit hopeless because I felt like there was nothing I could say in that moment to convince her that it wasn't real. Number 4, I used my critical thinking skills when working with a client admitted to the psych unit for alcohol addiction. My partner and I did both miss the fact that she was about to have a seizure, which is obviously a big mistake, but we learned from it. I did use critical thinking, though, when trying to determine if she had a substance abuse problem, because the information you had given us and the information she was giving us didn't really match up. I also assumed that she would feel a bit embarrassed and uncomfortable because she worked there. I'm a nurse, she's a nurse. So I was careful not to pry too much to where it came across as gossipy, and I also did not want her to feel as though I was like pitying her or doing anything to make her feel more embarrassed or ashamed. Number 5, the paranoid patient gave a lot of verbal and nonverbal clues. She was voicing what she was seeing and hearing, and she was also trying to climb onto the table to get her grandma back and began crying. And then after seeing the devil, she began screaming and crying again, and she began hearing command hallucinations, which told her to kill the nurses. Based on those clues, I determined that her priority problem would be ensuring her own safety and then making sure she's not a risk to others as well, since she was having those command hallucinations. 6, if I'm being completely honest, I am still working on my feelings towards those experiencing mental illness. I can be judgmental at times, which again, I'm working on. The CSI experience, though, really helped me because it just opens your eyes a lot, but also the schizophrenia audio, it was really uncomfortable and distracting, and it showed how something that seems so simple is so incredibly difficult when you have so much going on in your mind. And I was so excited to take the earbuds out, and in a moment, I think Miss Williams actually said it, they don't get to do that. They don't get to take their earbuds out. They have to listen to that all day, every day. And I know it's just like a little MP3 player and earbuds. To them, that's their mind. They can't take that out. So that was really eye-opening. 7, I was not part of the simulation with the deaf patients and the interpreter, but I did learn a lot from it. I've never been in a situation like that, but even just observing it, I learned so much, like positioning, pace your questions, look at them, not the interpreter. So I did learn a lot from that one. 8, I do feel a lot more comfortable completing mental status exams. It applies outside of mental health in healthcare. Like, there's a lot of questions where we're just really invading their privacy. In any other situation, you kind of want to tiptoe around it, but in healthcare, you have to get straight to the point. So asking questions like, do you want to hurt yourself? Are you planning on killing yourself? They're heavy, but getting experience doing it does make it a little less uncomfortable. 9, I learned how important the nurse and client relationship can be in mental health care. they can be so scared and embarrassed and not know where to turn, and you can be the one to give them direction, some reassurance, a sense of safety, and that's really important. And then lastly, my biggest takeaway is I need to be more observant of my surroundings and my patient. In both the scenario with the alcohol abuse client and my manic patient, I missed important details. So my patient's project was a huge fall risk. And I think my issue with that one was I wasn't thinking, oh, I'm going to fall, but the patients could have fell on that, and I should have been more aware of that. And then for the alcohol withdrawal, we didn't acknowledge her blood pressure or notice that her hands were tremoring. So I will make sure to be more aware of that. And I also think it's something that I'll get better with time. And the CSI and QSIN feedback are very helpful, and they do help me grow in my clinical skills. Thank y'all so much. I really do appreciate it.